I would like to introduce Maggie Buckley. Ms. Buckley has been a health and patient advocate for over 3 decades while living with Lewy-Dietz syndrome, a condition that causes joint hypermobility. She served on the boards of several nonprofit patient and professional organizations and has testified at health policy hearings, spoken at health conferences, and spoken to the media, written articles, and coached hundreds of people to self-advocate for better health care. Maggie has an MBA in accounting, and in 2019, she became a board-certified patient advocate. She has a lot of really practical advice at the individual level and the societal level, so I'm really glad that she agreed to come all the way to speak with us. And today she'll be speaking to us about Beyond the Bend, elevating care for people with hypermobile conditions. Come on up.
Okay, thank you. Got to get all my assistive devices and supportive stuff in place here in case I need my glasses. So, thank you, Dr. Minoka. Thank you to the rest of the team here. I am, as Dr. Minoka said, Maggie Buckley. I have Lewy-Dietz syndrome. I also have a rare type of Ehlers-Danlos syndrome. So I am qualified to be here on multiple levels here. And like our friend Catherine here, I was first diagnosed in the 1970s. We've been making it up as we go along anyway. So today we're going to cover types of advocacy, the setting for, and setting the stage for self-advocacy, as well as how advocates can enhance care. And I'll give you some tips on self-advocacy. I have no financial disclosures. I volunteer with multiple agencies and patient support organizations, et cetera. So you can look me up online. You can find recordings of past talks. You can find me on LinkedIn, et cetera. Our objectives today are to understand the different types of patient advocacy, learn how the things we need to do to be better self-advocates for ourselves, and to see how once you have a patient advocate on board or you're self-advocating, how that enhances care. So, as I said, I was diagnosed at the age of 13, way back in the 1970s, by a doctor who, he was an orthopedist. He was the orthopedist on call, multiple ER visits due to multiple joint dislocations, because I was doing all kinds of things like soccer, skiing, downhill ski racing, running, you name it, I was doing it, and I was just falling apart. So he did due diligence, and after a couple of months, he determined, okay, you have this hypermobile condition. It's genetic, can't be cured. It's called Ehlers-Danlos syndrome. Nobody's heard of it. Don't bother learning the name. Just tell people you have loose joints. You're never going to meet anybody else who has this. It's so rare. And so then he stops, he takes off his white coat, and he sits down next to me on the bench, and he says, now, as a person who has this, I can tell you, only you can set limits on yourself. So if there's things you want to do and things you want to try them. Just change up how you do it. Much like Dr. Cohen-Solomon was saying, you just need to adjust it. Most importantly, don't be afraid to say, nah, this isn't for me. It's okay. And he turned to my parents and he said, now, your job as parents is not to treat this child different or protect them. Your job is still the same as with your other children. You're teaching them to make decisions, learn about their body, understand the consequences of decisions, and learn how to set limits and boundaries. So go forth. No, he provided a multidisciplinary care type model at the time, which was very unusual. And it was a series of referrals to occupational therapy, physical therapy. He got me into a meditation study at Stanford, so I learned to meditate at the age of 12. And a whole bunch of other things. And the physical therapy referrals were for the physical therapist to teach me about specific joints, how they work, how to fix things, so that I would become self-sufficient later on. Great. I thought everybody did this sort of thing, and this is how healthcare was supposed to work. I was wrong. Thankfully, he also gave us another piece of advice, which was get a copy of Gray's Anatomy, learn about your body, learn the language, so that when you're talking to healthcare providers, they know what you're talking about, and you're not trying to say, you know, that thing on my knee, whatever. So that laid the groundwork for learning to self-advocate for me at a very early age. And I don't even know where I am on my slides. Anyway, I have decades of lived experiences where I was getting that. This presentation is inclusive. I'm not excluding any particular diagnosis. Here's a few listed on the screen. You have to keep in mind that hypermobility is significant in that it represents hundreds. Someone told me recently 700, and somebody else said, no, it's 900. Different conditions where hypermobility is a marker. So the clinics that are specific to these conditions are interchangeable to my mind because we're dealing with a lot of the same issues. So a Marfan clinic might be more focused on the cardiovascular stuff, and Loeys-Dietz might be also focused on cardiovascular as well as some orofacial issues, some dental issues, but they're leaving out of the equation because they're so focused on those more prominent things. They're leaving out of the equation the hypermobility. So when I see a hypermobility clinic, or an EDS clinic, as a patient advocate, I'm referring people to those clinics as well and telling them, don't tell them that you have that diagnosis. Tell them you're there for hypermobility to get the services and things that you need. So diagnosis can change as science changes. Remember I said I was diagnosed with Ehlers-Danlos syndrome at the age of 12, 13, way back in the 70s. Since then, science has evolved. And I'm in this bucket with all of you, hypermobility, and I keep being plucked out and put into other buckets. I'm old, so I've been in the Marfan bucket, I've been in the Loeys-Dietz bucket, I've been in the really unclear what this is, mystery connective tissue disorder bucket, and they keep putting me back in the hypermobility bucket and saying, that's your biggest issue. Let's focus on that. As science advances, as genetic markers are known and identified, people's diagnosis is going to change and evolve. The other thing that happens is that the nosology, or the classification of the different types, changes and evolves as science advances. So it's okay if your label gets changed. It's okay if suddenly someone says, no, you don't have HSD, you have HEDS, or you have Loeys-Dietz, because now we did this genetic panel that you participated in the testing for, and we found this TGFB3 variant, whatever it might be. Bottom line, advocacy applies across all labels of what we're having, and we have what we have, and we all share a common core set of symptoms. So if you're only focused on finding EDS resources or HEDS resources, you're limiting yourself. You should be interacting with the people in those other diagnostic groups. One of the best pieces of advice I got from somebody about 30 years ago was a gentleman with osteoporosis, or osteogenesis imperfecta. And he had these really cool finger splints. And I was like, whoa, what's going on? And he's like, I can't dress myself, I can't feed myself, I can't, do self-care because my fingers are so. And I said, well, where did you get those splints? And he told me about this new company, Silver Ring Splint Company, which was started by an occupational therapist, which was a much better alternative to the plastic ones or the stainless steel ones that we're all familiar with. plastic ones, if they're thin enough to have on adjacent fingers, they break, you gotta go back. Very expensive. Stainless steel, too bulky, can't have them on adjacent fingers. But silver ring splints are more like jewelry, which is what I have going on here. And so I didn't know anything about that, but because I went outside of my then known community of EDS, I got more information and learned more resources. So looking for that. So let's move along to types of patient advocacy. Patient advocacy takes many, many forms. There's awareness advocacy, and that's the people posting on social media. Oops, I knew I was going to do that. There's writing and media advocacy, where you're writing articles, you're volunteering to do interviews, you're calling into radio shows or podcasts, writing in, offering to be interviewed to share your experience with the healthcare system. Peer support, it isn't just support groups in meetings, there's online forums, etc. Education and public speaking, speaking at conferences, participating in webinars, training in your local hospital or your local clinic, being the speaker, the guest at a lunch and learn for a small practice. You bring the lunch and they listen to you explain your lived experience with your diagnosis. Did I cover legislative? I'll get to legislative. Legislative and regulatory advocacy, that's policy and system change. That's participating with elected officials and their staff members, they're the key people, to improve the system overall of what we're doing here. So storytelling for all of those types of advocacy is, sorry, I'm out of order. Okay. Storytelling is difficult to master. You basically want to do a couple of things here. You want to connect with them. I'm a person, you're a person, we have that in common. You want to break their heart by telling them all the problems you're having very quickly. And then you want to tell them how it can be fixed and tell them that they have the power to fix it and improve life for you. And the selling point where you drive it home is, and if you improve it for me, you improve it for you. So that's the formula. The trick is practicing saying this and getting it down to 5 to 10 minutes. The shorter, the better. And you can have different spiels for different elected officials or different situations where you're at. Wherever you're at, it makes sense. Legislative and regulatory advocacy is extremely important for all of these reasons that you see on the screen. We don't have enough services available to us. We are considered to be part of the normal healthcare system. There must be some specialist who can help you. You don't need anything special. So rare disease clinics are very limited. Access is almost impossible. And once you get that access, we aren't often offered continuing care. We might be given a diagnosis, some guidelines, and sent back to our GP without a whole lot of follow-up or the opportunity to contact them if something new arrives. Advocacy in the legislative realm and regulatory realm and in the administrative realm protects and expands those specialty services. So everybody here, if you get anything out of this event, send a thank you note, not only to Dr. Minoka, but to the sponsors of the event and the University of Calgary, and let them know that this is a worthwhile, much needed event that filled some specific need that improved your quality of life and your healthcare. That encourages them to fund and consider creating future events or expand this event. We want to improve care for complex conditions and strengthen care for everyone. So part of the sales pitch, again, if you fix it for me, you're going to fix it for you and everybody else. They know what's wrong with us because we've got these weird diagnoses. And research-wise, that helps them narrow down what they're looking at or what's an outlier. And they can compare that with a group of unaffected individuals, et cetera. So letting them know that that's part of what's going on here, that you are willing to participate in research, and it needs to be funded in order to improve the system for everybody, is what we want to do. You need to explain to them specifically why all of these things are essential. You want to share the human impact of what you went through because your diagnosis took however long. Of course, Catherine and I are the exception, but we still have an impact problem that we can share with them. Because I had this thing that nobody could pronounce, and when I said it, everybody just went, too rare. You want to connect functional outcomes. You want to let them know, look, if I have this kind of care and you provide this level of care for everybody else, I can work, I can go to school, I can become a contributing member of society, I can pay taxes, and I can support my community. Let them know how it's going to impact you in that way. You're selling, you get this. You want to reintroduce yourself to your elected officials after every election cycle. You're not going in with a specific ask of pass this legislation. You can do that later. You want to show up or contact them and their health staff people, because those are the people with magic power behind there. They're the ones that decide what the elected official is going to actually pay attention to or read. You want to let them know, I am one of your constituents. I have this rare disorder. I have experienced challenges in this healthcare system, and I'd like you to keep my face in mind every time a piece of healthcare legislation comes up. Further, if you're comfortable doing so, let them know that they can call on you as a witness for a hearing, to share a testimony, to submit comments, all of those things. Those health staffers are looking for that resource. Who do I call? Who do I get to come up and speak and stand with the elected official? This is important. A piece of advice that I was given early in my working career was identify and train your successors in everything you do. Notice that it's plural, because there's not going to be just one person that replaces you. So bring people along. Start with your family members, bring your friends, your coworkers, and then just start grabbing the public people that you encounter. If you're at an event like this, you hear somebody talking out during the break, and you think, oh, I think I can learn from them. Ask them to mentor you. Likewise, if you hear somebody talking and they need some support, some connection, some correction in what they're talking about to make sure it's factual and accurate, offer to be their mentor, offer to connect with them. This makes all of our impact exponential. This means things will change. So now let's move on to talk about interventional advocacy. What happens in the exam room? Repeated dismissal can wear you down. And you keep hearing, everything looks normal, we've done the tests, we've done the x-rays, nothing shows up, blah, 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 blah. You've heard it all before. And so it's no wonder we're anxious or not looking forward to going to the doctor. We want somebody else to go in and do the talking for us because we're so tired of doing it. And that's where an advocate comes in. We want to, I told you I was going to do that. An advocate can help communicate clearly and make sure that you're heard. And that advocate can be in the room with you. They can be someone who helps you prepare for the appointments, et cetera. We'll go over the different types in a moment. The ultimate goal is that the provider understands what's going on with you, and that healthcare practitioner knows there's options, and you're willing to collaborate with them, which makes them willing to collaborate with you. So, what are we talking about when we talk about an interventional advocate? It could be a family member. Growing up, we had our parents speaking for us, right? We got used to that, and then we got thrust into the adult world of the healthcare system. A lot less supportive than the pediatric system. So, and the key tasks that need to be done are collating your medical records, making appointments, confirming appointments, making sure you have coordination between your healthcare providers. A peer patient advocate can often, in this section, a peer patient advocate might be related to a healthcare system or a clinic. So it's somebody else with a similar diagnosis that they've decided it goes easier with these patients if we have somebody with similar lived experience to partner with them and make them feel less alone. So, but that person is going to give you guidance of who to call, maybe within that clinic or within that system. So it's inside that system. A nurse case manager and patient navigator, they're often, they're employed by an insurer or a healthcare system, so their allegiance might be more towards their employer and their employer's interest rather than the patient's interest. And then there's an independent professional patient advocate. I'm a board certified patient advocate. This is the type of work that I do, work directly for a patient. And my allegiance is only to the patient and the patient's outcomes. Now I'd like to focus on self-advocacy and share tips to help you advocate more effectively for yourself. These tips are also useful if you work with a professional advocate, because this is the work that you don't have to pay them to do, the things that we're covering. Because they're all going to start in this way. We all want to become better advocates for ourselves. And how many of you have ever been in the position where you leave an appointment and you think, I could have said that better? Right? I should have said it this way. It's because you went in there, you kind of knew what you were going to talk about, you hadn't practiced, you said whatever came to mind, you were anxious, so it was already confusing to you, you may not have connected, it didn't work out. So these are the types of things we want to do to prepare to do that. So the first task, we're talking about a bunch of stuff you're going to do before you even go to the doctors. So the first task you're going to do is compile all of your medical records. You want to be in control of those copies. Now, there's tools that you can get to help you do that, including apps like Primary Record or Guava to collate things, and those things will create a one-page summary for you. Ideally, you want to be able to have a one-page document, one sheet of paper. On one side is your diagnoses, the dates you were diagnosed, treatments that you have tried and have worked. If you have room, time, energy, you can add things that didn't work. On the second side, you want to make sure you have all of your medications. That's prescription, over-the-counter, and supplements when we talk about medications in the healthcare system. You want to indicate your allergies, any food intolerances or problems that you have with environmental allergies, et cetera. Those should be noted. Make sure you add your demographics, sometimes as a header or a footer of your name, your ID number, your emergency contact, your insurance record number, whatever it might be. And if you have room, add your primary care physician's contact information or any key specialists that you see regularly. This is brilliant because now you have created the piece of paper with all the information that a first responder is going to need when you call for an ambulance. They are trained to look at on the back of the front door or on the refrigerator for this information. And if you have a chronic condition, one of the best things you can do for yourself, the only thing you get out of today is that you produce this, you are ahead of the game. It's a living document. Obviously, it will need to be updated. Tip number 2 is to give yourself time to list all of your healthcare issues, all of your symptoms, all of your concerns. Give yourself a week or 2 because you might not be able to think of all of them all at once. And it is actually a cathartic experience to go through this, of writing it all down or putting it into a document or in the Notes app on your phone. Then give yourself some breathing space, and when you're ready to revisit it, rank each one on how impactful it is. How much does it interfere with your daily life, your ability to participate in life? On a scale of 1 to 10, 1 being the least, 10 being the most. And you want to sort and focus that. So all of the number 10s, you want to group together, 9s, etc. And then you want to think about, realistically, where do I need to focus my time and energy? Because every time, before doing this exercise, every time you're going to the doctor, you're thinking, I got 783 different things I need to talk to them about. And these are the 3 that I can think of right now. Yeah. And I have 7 minutes left. So you want to sort and focus that, and you want to group it by body system if possible. Still, before the appointment, you want to track those symptoms. You want to take all of those things and use any tool, any tracker, anything that you have available to you, and identify clear triggers for what's going on. You want to have some words and some data to back up what's going on with you when you're in that appointment. Finally, the appointment's next week. You sit down, you look at all the data you've collected, you look at all the lists of things that you have, you describe your top 3 issues you want to cover in that visit in 3 sentences or less, or in 2 sentences or less, and you practice saying them. You want to ask clearly for help and what's the next step in there. And I'm going to run over and into questions. If you don't have a diagnosis, where do you start? Start with your primary care physician. You're looking for curiosity, compassion, and courage. You're looking for somebody who's willing to work with you and collaborate with you. They don't need to be a hypermobile expert at this point. What they need to be able to do is a clinical exam, and they need to ask you questions. So don't feel bad when you go in and you say, I have this thing, and I'm worried about it. Don't open with, I've researched it, so this is what I know I have, and I need you to take care of it. Expect them to ask questions. Invite them to ask questions. It's more safe to proceed this way because you then know they are going through the differential diagnostic process in a reliable and safe way. More questions don't mean they're dismissing you. It means engagement. It means they're going to work with you. So the last few slides have to do with training pathways. If you want to be a patient advocate, there's a lot of pathways from patient support organizations to professional organizations. And then on the next few slides, I have some links, but don't worry, there's a QR code at the end with all these links. So, and some other resources, Primary Record and Guava. And then on Instagram, there's 4 particular accounts that I like to refer you to. They have very good information from a lived experience point of view, and it's science-based, factual-based, talks about adjustments. So Jeannie DeMond gets her second shout-out of the day in that way. And we can ignore that. And there's the QR code for you with all of those links.
Thank you.
Don't forget to share your email address so they can send you a thank you note.
Oh, thank you. Let's see, there was a lot of questions here. Just got to put it back to the right spot. Well, you want a shout out too? Someone says, Maggie's the best. Thank you for everything you do for folks with Lewy bodies, EDS, and other hypermobility conditions. There's quite a few questions about how do you handle it when you have a physician, whether that's a family physician or another type of physician, being skeptical about either your condition or the diagnosis, that sort of thing. You kind of talked about a few tips, but there's a lot of questions. If you can expand on that a bit.
Remember, if you're using the tips that I presented, you have data to back up what you're saying about the symptoms. So if a physician is still skeptical in that way, send them a letter afterwards. Send them a message through the electronic healthcare record afterwards that says, look, I think you missed this symptom that I described, and I've been tracking it. And in the last 30 days, I have felt like my knee has given way underneath me as I've been walking 17 times. And when that happens, this is what I've done. I've stopped walking, elevated my legs, straightened it out, massaged it around, and it takes about 30 minutes for it to recover. But I don't really understand why this keeps happening or what I can do to prevent it, and that's what I need your help with. So being specific, remember you've been collecting that data. You know how many times it happened. You know what you were doing when it happened. You know what you tried to fix it. But you don't really have the opportunity to communicate all of that in the appointment. You can send them a message with the additional details and let them know, I'm tracking my symptoms. I am trying to figure this out.
Thank you. And I will just quickly add, as a physician myself, and understanding that your physicians have their own limitations and agendas, and it might be different from yours, right? Some family physicians might only have 8 minutes to spend with you. So like Maggie was saying, the more specific and focused you can be, a family physician unfortunately just doesn't have the time to read like a 5-page letter. The more specific you can be about your symptoms, the trends that you're noticing, and its impact on you, and specifically what you need. Like if you can even phrase that as a very short question, I'm concerned about this. I was wondering if I could get a diagnostic test or something like that. It's really helping your physician help you. There is on our lab website, ctdrc.ca, kind of a lecture about navigating physician interactions and how you can really work to help your physician in a resource-limited system help you. Thank you, Maggie.
Yeah, it's really hard because we've been dismissed, and when someone's finally listening to us, being able to narrow it down to, I need to tell you in 2 sentences, this hurts, and I want from you.
Mm-hmm. And people have asked about sharing the slides, so there will be recordings that will be sent out to everyone.
And if you email me here, I can send you a slide deck as well.
Perfect. So here in Alberta, there's been a lot of government changes to healthcare, so just a little bit more on specifically advocating with government around healthcare policy change. And in Calgary, there's been a few questions about lack of access to clinics and that sort of thing.
Yeah, again, clinics are limited and referrals are hard to get, and there's a long waiting list. This is true around the world. It's not unique to Alberta, it's not unique to Canada. It's the same everywhere. So working with your primary care physician as best you can to take care of all of the low-hanging fruit, including your regular maintenance stuff, including your annual checkups and screenings, et cetera, is a good place to start. Second is, as I said, remaining in contact with your elected officials. And as policy changes, policy doesn't change like that. Policy changes over a span of 5 to 10 years, which is, it exceeds the amount of time that somebody is in office. That's why every election cycle, you're back in there saying, remember me? I have this thing, and these are my challenges, and I need your help getting access.
Thank you. A few people have asked, there are some clinics in existence, maybe not necessarily in Calgary, where they do limit, certain diagnoses can't access this clinic. So, for example, some people with Lewy Dietz can't access a clinic in Toronto or myopathic EDS, things like this. So how can those patients kind of over time advocate for care for themselves?
Talk to the other patients in all of the diagnostic categories. One, to find out who they're seeing in their local area or your local area is one way. Again, advocating with administrators and letting them know, sure, this is an EDS clinic, but I have these hypermobile issues and there's no place else for me to get care. I need to be admitted to this clinic. Because let's face it, if you have Marfan's or Loeys Dietz, everyone's big concern is you're going to drop dead of an aortic dissection right now. They're not paying attention to the chronic pain or the chronic dislocations. And that's where you're going to get that help, because that's where we've been concentrating that and that training. That's how we got Dr. Minoka and the Better Mobility Clinic going, because we said this needs to happen.
Takes time. Some people have also asked about specific peer support groups. I don't know if there's any that you recommend or.
The Ehlers-Danlos Society has a lot of, as does the Marfan Foundation and Loeys Dietz Foundation Canada, et cetera, have a lot of patient support networks that are called out on their websites. They offer a lot of virtual gatherings, et cetera. I participate in 4 or 5 different ones virtually throughout the month in that way. And they're international. And so maybe you're a night owl or an early bird, so choose a different country. If you speak another language, Spain has some great support options if you can speak Spanish. France, likewise. If you speak French, look at what's offered by the French connective tissue disorders. And the Australia Connective Tissue Disorder Network is also an excellent source for support.
Great, thanks. And we also have lots of support groups from the UK. They seem to do a lot, particularly with hypermobility spectrum disorders and HEDS, and they're on ctdrc.ca. This has been great. Lots of questions coming in. And I just wanted to remind people to make sure that you're putting the question in the right room. We've been trying to catch it when people have been putting it in the wrong room, but to do that, it's just at the top, you can select the right room for the speaker so we can make sure that we're getting them. Do you have any tips for how we as a patient group can sort of educate physicians about these conditions so that they're asking the right questions? Because as patients, what seems normal to us, physicians might not even think to ask.
The challenge here is that patients tend to go in and say, I have this thing and you know nothing, without even asking. So instead, practice ahead of time and think in terms of how can you put it in the most basic terms. I have joint hypermobility rather than I have X diagnosis. I'm here because I have joint hypermobility and poor proprioception, and I'm looking for help with physical therapy, but I haven't found any resources in this area. My research shows that these are the things I need to be doing. I need to find someone who's familiar with Jeannie Dubon's integrative movement method and has been trained in that here locally, which there are around the world, people that have done that. And in that statement, you've now educated the physician that you have this thing, you know what the issues are, and that there is specialized care. Can they help you find that specialized care or find someone who's willing to provide that specialized care? You can also share resources, the websites, the articles as they're published. They're coming out fast and furious because science moves so fast now. The Ehlers-Danlos syndromes will be, the new classification will be published December 1st, along with new diagnostic and treatment pathways, which will be published in March of next year. So when those articles come out, you send a friendly message to your physician through the electronic health portal and let them know, I just want to make sure you know this was just published. You're not reiterating the information that's in there. You're letting them know this is a resource that they may not have found.
Thank you. So I learned sort of in the first talk a lot about maybe pacing, conserving our energy, but it takes a lot to live with a chronic illness. And then how do we add this in? How do we advocate for ourselves, and where are our efforts best spent? Is it individually, politically? Any thoughts about that?
There's no insignificant advocacy. And you can always find somebody, hire somebody, ask a friend or family member to advocate for you, which is part of teaching and learning in the community as well. So you don't have to do it all at once. But if you're stuck in bed because you're in chronic pain and you're having difficulty moving, in addition to movement hacks like the tongue in the mouth Dr. Cohen-Solomon talked about, there's other things that you can do while you're there. While you're doing those movements, think about, how do I describe this? Who would I be describing it to? And practice, again, those words in your head. If I'm talking to my mother, I'm going to describe it as this. If I'm talking to my doctor, I'm going to describe it as this. If I'm talking to my boss, I'm going to say it this way. Or how do I explain to a legislator why this moment in time, my worst moment in time, is important and they can fix it?
Awesome. Well, thank you so much for coming. I really appreciate it.
Thank you.